So again, a very warm welcome to all of you. In this video, we will be going to discuss about edema. Why it is important to discuss about this topic? Because in different subjects, you will listen the patient is showing the symptoms of edema. The patient have edema and different organs have different pathogenic mechanism of formation of this edema. So you must know for what organs? Like we have different type of edema. We have cardiac edema, pulmonary edema, hepatic edema, nutritional edema, and mixed edema. So what is the mechanism of formation of these different kind of edema? What does it mean edema? Yes, so we must know because if it will be pulmonary edema, so there will be the different pathogenic mechanism for its formation and will be the different treatment. So it's necessary to know the pathogenic mechanism. So let's discuss in detail now. So now let's discuss the definition of edema. What does edema says? So it is defined as the presence of normal and excessive accumulation of free fluids in the interstitial space and tissue cavities. Means whenever there is the accumulation of the abnormal fluids in the interstitial space and tissue cavities, we call this situation as edema. We know why we see in the interstitial tissue space and serous cavities because sometimes there is abnormal collection of fluid within the cells, and this is called intracellular edema. Suppose we have some cells, and inside these cells there is accumulation of some fluid. An accumulation of this fluid is not called edema. It is within the cell. We call this situation intracellular edema, or better to say hydropic changes. Now, the first one is free body fluids. Free fluids in the body cavity. So, in this condition is called as effusion. This condition is called as effusion. For effusion, it is named according to the body cavity in which the fluid accumulates. It's very simple. You know, ascites for peritoneal cavity, hydrothorax or pleural effusion for pleural cavity, and if the fluid accumulate in the pericardial cavity, then it is hydropericardium or pericardial effusion. The next one is free fluid in interstitial space. Means when fluid present in interstitial spaces. This term is commonly known as edema, and the fluid lies in the interstitial space between the cells. Suppose we have one cell and another cell, and between these two cells we have this space. This is called interstitial space. Fluid start accumulating into these interstitial spaces, and this condition is called as free fluid in interstitial space. Then edema can be of two types. It can be local edema and it can be generalized. So what does it mean local? Local means if accumulation of fluid in the lungs, then it will be only in lungs. It will not migrate to other organs. So local edema. So the examples of local edema are pulmonary edema, cerebral edema, lymphatic edema, and inflammatory edema. And for generalized edema, generally for generalized edema we have an and dropsy when it is in systematic distribution, particularly noticeable in the subcutaneous tissue. The examples of generalized edema are renal edema, cardiac edema, and nutritional edema. And the types of edema can be also on the basis of the presence of fluid, because we know edema is due to the accumulation of fluids, And these fluids, the nature can be different. These fluids can be transudate and can be exudate. I will give you this information during the lecture of inflammation when we will having exudative inflammation. So during that portion, I will tell you what does it mean transudate and exudate. Now, I just tell you that exudate is inflammatory edema. Whenever you see edema is associated with inflammation, so the fluid named as exudate. The fluid named as exudate. This exudate is rich in neutrophils. You can say predominance of neutrophils. And transudate is non-inflammatory fluid. This type of edema found in cardiac disease and renal diseases. And now, today we will discuss about the different pathogenesis of edema. So we have decrease in plasma oncotic pressure. Whenever plasma oncotic pressure decreases, it leads to edema. How we will see increased capillary hydrostatic pressure, lymphatic obstruction, tissue factors, increased capillary permeability, and sodium and water retention also leads to edema. So today we will be going to discuss in detail how decrease in plasma oncotic pressure leads to edema, how increase in capillary hydrostatic pressure leads to edema, and also about rest of the factors. So let's first discuss about how decrease in plasma oncotic pressure lead to edema. So we know that the oncotic pressure helps in the flow of fluids. Yes. Okay. So first of all, this is the normal condition. Normal fluid exchange is there because to understand the pathology, you must know what are the normal condition, what is the norm for each condition. If you will know the normal pathology, then you can easily relate what changes are going. Okay, and to differentiate these changes, we can easily differentiate what kind of pathology will be there. So first of all, let's discuss about decreased plasma oncotic pressure. So before this, I already told you that you must understand the normal conditions. What is normal fluid exchange mechanism? So we have arterial and we have venous and this is our capillary, we can say, and this is the endothelium through which exchange of material take place. And this is our interstitial space, and in this interstitial space we have different cells. Yes, and from we know from the interstitial space the movement of fluids through the lymphatic outflow. Through the lymphatic outflow. So here, what is necessary to see? In case of plasma oncotic pressure, here we have presence of plasma, and when this plasma oncotic pressure decreases, and outside the oncotic pressure is normal generally, but this pressure will be higher when this pressure will be decreased. And we know what is the movement of fluid in case of osmolarity from the low oncotic pressure to high oncotic pressure. The osmotic pressure is reduced inside the capillaries, and from the capillaries the fluid will start leaking out to high osmotic pressure. So the main thing is that why this osmotic pressure is reduced, because we know the oncotic or osmotic pressure is maintained by proteins, mainly albumin. Now question is why only albumin? We also have other proteins because albumin has oncotic pressure 4 times higher as compared to other proteins. So the plasma oncotic pressure proteins when decreases, it leads to fluid into the vessels. Outside of these vessels, so we can say whenever there will be hypoalbuminemia, means decrease in level of albumin, we are talking about decrease of plasma oncotic pressure. And when there will be the decrease in condition, there will be outward movement of fluid from the capillaries. The outward movement of fluid from the capillaries into the interstitial space will lead to edema. So now we can clearly understand why decrease in plasma oncotic pressure, because of low protein content, and this low protein content is due to low albumin, hypoalbuminemia, and the movement of fluid from the low oncotic pressure to high oncotic pressure. So this is very easy to understand, but I don't know why 90% of students confuse when they decide to answer to teacher during exam or checkpoints or during their unit test. They make situation sun is revolving around earth or earth is revolving around sun. But okay, leave. That is not our task. Our task to understand this pathology. And hope you understand. During exam, do not make mistakes. Decrease pressure there and it's very simple. If you know the normal osmotic changes, normal when there will be the changes in the osmosis. So we know from the low pressure to the high pressure, and you see decrease of plasma oncotic pressure. If plasma oncotic pressure will decrease, so there will, why it is decreased, because of low protein content. Which protein? I mean mainly there will be the low protein content, then the fluid will pass from the low protein content area to high protein content area, and this accumulation of this fluid into the interstitial fluid. Now there must be one question in your mind: if there is no lymphatic blockage, so this excessive fluid can be easily passed through these lymphatic channels. So why edema? Because the fluid is in 4 times excess as compared to the drainage. That's why it leads to edema. Every single mechanism and pathology have its own reason. So try to understand the reason, what behind the disease. Do not muck up the thing, do not mix up things. Try to learn. So we understand this. And this type of edema we can see in renal diseases such as in nephrotic and nephritic syndrome. Remember, now I am explaining you the decrease in plasma oncotic pressure. If you will remember in what disease, what pathology it is, then if someone will ask you that what is the what is the reason for formation of edema in renal disease in case of nephritic and nephrotic syndrome. So you remember that decrease in plasma oncotic pressure responsible for edema of renal tissues, and if you will tell the same mechanism, you will get excellent marks and you will be excellent doctor. This problem also present in ascites of liver diseases, cirrhosis of liver, and edema due to other causes of hypoproteinemia, means such as protein losing enteropathy, because the main reason of this type of edema is hypoalbuminemia. Next is increased capillary hydrostatic pressure. We know that the hydrostatic pressure of the capillaries is responsible for normal flow of fluid through the capillary wall into the interstitial space by counteracting with force of plasma oncotic pressure. You know, we have capillary pressure here, and this capillary pressure to come out this fluid. Okay, if this pressure will be increased, remember the condition is same. Fluid will come out. In previous condition, it was due to low oncotic pressure. But here, the capillary pressure increase means where the fluid wants to go, the force responsible for its increases. So if capillary pressure increases means capillary hydrostatic pressure increases, then it's a favorable condition and fluid automatically will come out from the capillaries into the interstitial tissue and it will lead to the edema. And such type of edema we can found in cardiac disease such as congestive heart failures, constrictive pericarditis, cirrhosis of liver, in case of obstruction such as thrombosis of lower legs, and postural edema means edema due to the posture of the patient. Sometimes we can see some people have work with long standing positions such as doctors, long duration of surgeries and very busy surgeons and teachers. So due to their long time standing position, there is the transient edema of feet and ankles. Next is lymphatic obstruction. Normally, we know from the interstitial tissues, the fluid pass through the lymphatic outflow. But when there will be the obstruction of this lymphatic outflow, there will be the no drainage, and if there will be no drainage, then fluid start accumulating in the interstitial space, and it will lead to edema. When there can be obstruction, obstruction may be due to the removal of axillary lymph node because of carcinoma of breast, and maybe there is pressure from outside on the abdominal or thoracic ducts. It may be due to tumors, and it may be due to any fusions in the serous cavities. We know when these main lymphatic system ruptures due to overpressure, it will lead to discharge of fluid into different cavities. Remember, if the fluid will go to the pleural cavity, then we will say this condition is chylothorax. So what is chylothorax? CHYLO. Chylothorax. This is the discharge of fluid into the pleural cavity, and if the discharge of fluid into the peritoneal cavity, then we can say it is chylous ascites. Remember, I want to tell you about one disease that is Milroy disease. It is associated with the lymphatic obstruction. It is associated with lymphatic obstruction. So Milroy disease or hereditary lymphoedema. This is due to abnormal development of lymphatic channels. Means since from birth the lymphatic channels are not functionally active. It is swings in families and the edema is mainly confined to one or both lower limbs. Then the next is tissue factors. What is responsible for tissue factor mechanism? In this case, there is the increase of oncotic pressure of the interstitial fluid and decreased tension. You know, if there will be the increase of osmotic pressure or oncotic pressure of this area, then here in comparison to this area, because here increase this pressure will be the low, means the plasma oncotic pressure will be low, and we know fluid will pass from low oncotic pressure to high oncotic pressure area, lead to accumulation of this fluid again in the interstitial space, and it will lead to edema. Simple conclusion, everything is same. And this elevation of oncotic pressure, why? The question is this: due to increased vascular permeability and maybe due to Inadequate removals of protein by lymphatic means through the lymphatic system. We know generally this capillary membrane is semi-permeable. It allows to pass water and electrolytes through it, but not proteins, only selective proteins. Sometimes it leads to increase of its permeability means leads to more space to passage of proteins because of injury, and it leads to permeability increase of the membrane. And when the permeability of this capillary membrane increase, it will lead to of albumin from here to here, and it will drainage out through the lymphatic system. And if it will be drainage, here will be low, here will be high. Edema, increase capillary permeability. Right now, I explained you already. The capillary permeability increased. It may be due to the injury. Injury leads to increased vascular permeability because we know it is a semi-permeable membrane which permit only the flow of water and crystalloids and minimum amount of plasma proteins. So, due to development of gaps between endothelial cells, it will leads to leakage of fluid, development of gaps. The arrow shows the development of gaps and leakage of proteins outside of this capillary into the interstitial space and leads to edema finally. And mainly it is inflammatory edema in infectious disease such as allergic reactions, edema due to retention of sodium and water. Why there is edema due to sodium and water retention? So let's have three mechanisms. The first one is extrarenal, intrinsic renal, and ADH mechanism. So the first one is intrinsic mechanism. So it is associated with the hypovolemia. What does it mean, hypovolemia? Hypovolemia means reduction in effective arterial blood flow. So, this sudden reduction in the arterial blood flow is called hypovolemia. And why sudden reduction? Because there is loss of blood. If there will be the loss of blood, then there will be the reduced arterial blood flow. So, it may be due to injury, hemorrhage. Hypovolemia leads to stimulation of arterial baroreceptors. You maybe not see it properly, but it is written baroreceptors, which are present in the carotid, sinus, and aortic arch, which in turn this sends signals to the sympathetic outflow. This here written sympathetic outflow. It sends signal to the sympathetic outflow via the vasomotor center present in the brain. So this is vasomotor activity which is present in the brain sends sympathetic signals to the outflow. As a result of this, there will be the renal ischemia, and this renal ischemia leads to reduced glomerular filtration rate, and the reduced glomerular filtration rate, then there will be the retention of fluid inside the body, and there will be the less excretion of sodium, and accumulation of sodium and water retention will leads to increase in blood pressure and edema edema. We also have another mechanism that is called ADH mechanism. Whenever there is activation of antidiuretic hormone in from the posterior pituitary, it leads to retention of water, and retention of water leads to edema. What are extrarenal hormonal effects? We know first of all there will be the ischemia. This ischemia will leads to decrease in GFR. Decrease in GFR will leads to decrease excretion of sodium, decrease excretion of sodium, so there will be hypertension, and in response to hypertension there will be the activation of angiotensin system. This angiotensin system, which leads to release of aldosterone in adrenal cortex, and which will leads to sodium and water retention. This retention of sodium and water will leads to edema. Yes, so to maintain everything, every system, so we see 5 or 6 different mechanisms. Yes, yes. Let's see the important types of edema. I already told you when I gave you information about different kinds of pathogenic mechanism of formation of edema. I also gave you the example. This type of mechanism is responsible for what pathology. So we know renal edema, and I already discussed about renal edema, that edema may be due to nephritic syndrome, maybe in nephritic syndrome, and it may be in acute tubular injury. And I gave you information that in case of renal edema, it is mainly due to the hypoalbuminemia, means it is due to decreased plasma oncotic pressure. And if you know the mechanism of decreased plasma oncotic pressure, redefine the same, recall the same, and you can, if someone asks you, suppose your teacher asks you, what is the mechanism of formation of renal edema? Remember, renal edema is due to hypoalbuminemia, means decrease in oncotic pressure. If you remember how the decrease in oncotic pressure leads to edema, you can define. So your answer is correct for renal edema. Yes. The next is cardiac edema. How in the heart edema? So you know, I told you about decrease in arterial blood flow. Yes, and decrease in arterial blood flow will lead to decrease in cardiac output. And I told you decrease in arterial blood flow was called hypovolemia. You remember that situation when I gave you information about hypovolemia. And that hypovolemia will lead to activation of different systems. I already gave you information. Renal, intrinsic and ADH. Now the image is clear, you can see. And this was the type of sodium and water retention. So if somebody asks you what is the reason for cardiac edema, remember only sodium and water retention. That's why you will remember that sodium and water retention leads to what pathology. You have no need to separate to read the cardiac edema pathogenesis. No need, because you know what mechanism and what examples. And you know the finally the disease. So cardiac edema, I gave you example in hypovolemia, extrarenal mechanism, intrinsic renal ADH. I already explained you. If you don't understand, go back and repeat. Now, I want to tell you about 2 additional mechanism of formation of edema in case of cardiac edema. So in case of cardiac edema, there is elevation of central venous pressure. This elevation of central venous pressure is mainly due to the heart failure, which leads to transmitted backward of venous and of capillaries, which leads to again increase of capillary hydrostatic pressure and consequent transudation, and this is known as back pressure hypothesis. So central venous pressure increase in response to this, there will be hydrostatic pressure will increase, and you know this is capillary, this is interstitium. When this capillary pressure will increase, movement of fluid from intestine to outside into the interstitial space, and it will lead to the edema, and it is the case of cardiac edema. Then the edema is called cardiac edema. Another mechanism, in case of heart failure, it will lead to the hypoxia. When there will be the hypoxia, so due to this hypoxia, there will be the increased capillary permeability, and increased capillary permeability will lead to more passage of fluid from the capillary to the interstitial, and finally will lead to edema. Nothing is new. Everything is repeated. Everything is repeated, whatever I explained you. Again, pulmonary edema. Now, the difference is that cardiac edema present in the heart and pulmonary edema in the lungs. The mechanism are almost same. But you must remember that pulmonary edema was due to what? So pulmonary edema is mainly due to the two mechanisms: increase in hydrostatic pressure. Which hydrostatic pressure? Pulmonary hydrostatic pressure. If there will be the increases pulmonary hydrostatic pressure, then there will be the fluid into the interstitial space. And if there will be fluid into the interstitial space, it will lead to the interstitial edema. Fluid will further pass into the alveoli. It will lead to the alveolar edema. Yes, and you know the complete mechanism for increased hydrostatic pressure. It was the second mechanism what I explained you. It is due to increased vascular, but it was second. It was second last. Yes, maybe. Check. Then increased vascular permeability. Due to increased vascular permeability, I told you increase in gaps. Increase in gaps will lead to passage of fluid again to the interstitium, will lead to the interstitial edema and passes to the alveoli, to alveolar edema. Now, next one is cerebral edema, means swelling of brain. This condition is life-threatening because in brains there are no draining lymphatic channels. The functions of electrolyte exchange is performed by blood-brain barrier (BBB), which are located in endothelial cells of capillaries. Cerebral edema is of three types: vasogenic edema, cytotoxic edema, and interstitial edema. The first one is vasogenic edema. So in case of vasogenic edema, there is the increased filtration pressure, or we can say increased capillary permeability. The mechanism will be the same. There will be the increased capillary permeability. Increase of this capillary permeability will lead to passage of fluids into the interstitium and will lead to edema. In case of cytotoxic, there is cellular osmoregulation disturbances, and in case of interstitial edema, there is the excessive fluid across the epidermal lining of the ventricles and accumulation in the periventricular white matter, and this mechanism is responsible for edema in non-communicating hydrocephalus. Then we have hepatic edema, means edema in liver. What is the normal function of liver? Albumin synthesis. If will be the problem with the liver functions, means disturbance of liver functions, then it will lead to decrease in level of albumin. Decrease in level of albumin will lead to hypoalbuminemia, and this hypoalbuminemia condition will lead to low oncotic pressure of plasma. So low plasma oncotic pressure and high plasma oncotic pressure in comparison to this will lead to accumulation of fluid into the interstitium between the cells of liver, means between the hepatocytes, and it will lead to hepatic edema. It may be due to the portal hypertension and may be due to the inactivation of aldosterone, because we know the functions of liver is breakdown of aldosterone, And if there will be no breakdown of aldosterone, then it will be leads to hyperaldosteronism. And if there will be the activation of aldosterone, it will lead to the retention of sodium, and this retention of sodium will lead to edema. Everything the same I explained to you. Then the next is nutritional edema. This type of nutritional edema is mainly what is nutrition? The nutrition for our body has protein and vitamins. So in case of deficiency of vitamins such as vitamin B1 deficiency, in case of beriberi, protein, in case of protein we have Kawashiko disease. Yes. So the main factor are hypoproteinemia, sodium and water retention. Almost everything. Hypoproteinemia means less amount of proteins. And what proteins? Albumin. And this condition develops in especially economically deprived communities in Africa and Asia, and it is associated with mucocutaneous ulceration and depigmentation of hair, which leads to normal adequate nutrition. The last one is myxoedema. Myxoedema is mainly due to hypothyroidism. It is a form of non-pitting edema. We have two types of edema. One is pitting edema, another one is non-pitting edema. What is the difference between them? Okay, let's have an example. Suppose we have two area number one and area number two. Here we have pitting edema, here we have non-pitting edema. So when we press this area by finger, the fluid will move to other space and this part will be depressed. So this is pitting means depression. And in case of non-pitting, there will be no depression means it is solid edema. Swelling. Edema means swelling. So it is solid part. It may be cyst, it may be tumor. Yes, and it presents on skin of face and other parts of body such as internal organ due to excessive deposition of mucopolysaccharide, mainly glycose aminoglycan. You have already this knowledge from the previous topics, from the trophy. Yes, swelling. You have already studied maybe about different swelling. You have studies about mucoid swelling. And in case of mucoid swelling, there is accumulation of mucopolysaccharide, mainly glycose aminoglycan. It is the same case. So the reason for myxoedema is mucoid swelling. Okay, so I gave you information about edema. Remember this information. Use this information in different subjects. Relate this information. Recall and repeat the material. Thank you very much. Have a good day and maybe good night.